Hello, I'm Dr. Malescu, and I'm your instructor for pathophysiology. And this week you have an assignment that's super important, and I wanted to go over it. And then I procured a disease that is genetic, and I wanted to share it with you just so that I can give you a variety, other than what you see in your notes for Module 1. So let's first go over what the assignment is all about. So you're going to pick a disease. I happen to pick beta thalassemia major, and I'm going to go over that in a minute. You want to be able to describe the disease. What are the signs and symptoms? What is the pathology genetically? What gene is it on the DNA? Because, we discovered most of the genes on the DNA thanks to the Human Genome Project, which ended in 2000, where we discovered all the genes. Of course, we have junk DNA where we don't know yet their function, but we have that ability now. So if it is a genetic disease, which you're going to pick a genetic disease, make sure that that is a major point. And so you don't want to lose any points, no pun intended, but that is a major point of doing a genetic disease, is to identify the gene that is affected. Okay. Details regarding how these genes are affected, details of signs and symptoms of the disease. Okay. So not only which gene is it, but how the genes are affected. Is there an inversion? Is there a deletion? Is there some kind of absence of a sequence, etc., right? That's what deletion means. Signs and symptoms means what are the signs that you have the disease, and then the objective symptoms that are the findings. And then, of course, the current treatment options, yes. Not only the standard treatment of care in allopathic medicine, but if there is alternative, you may mention it. Not that it is effective or not, we don't judge it, but stick obviously first mainly with the standard of care that MDs and DOs and nurse practitioners and PAs, know that is the standard of care. Okay. Then we go to part 2, epigenetics. So this one, for my lesson today, I'm not going to pick a cancer drug because this lesson would be way too long. I just picked one disease that I'm going to discuss with you. And like I said, it's beta thalassemia major. So when it comes to epigenetics, you're going to choose an epigenetic cancer that you will describe the mechanism of action, the pharmacological action. How does it work? Okay, describe the drug, the mechanism of action. How does it work to fight cancer or treat cancer? Perhaps it doesn't kill the cells. Maybe it's just there to lessen the symptoms. Okay. And then, of course, discuss the efficacy of the drug, the side effects of the drug, the benefits of the drug. Okay. And that is your assignment for this week. Everything is due on Sunday. It is now Thursday, so I know I should have done this yesterday. I'm sure some of you have already started, but I'm glad that I'm at least gave you some time to think about it so that by the time Sunday comes around, you're not cramming. Make sure it's at least 300 words. I can't tell you enough how people try to cut corners and literally just make it 300 words. 300 words is minimal to get a C. Okay. 300 words is not going to cover a disease. All right. It just doesn't. 300 words is probably just going to cover the first part, where you're just talking about what genes are affected, where and how, and maybe signs and symptoms, but it's not going to cover talking about the treatment options and all that. Okay. So be aware of that. I know some of you emailed me on that, but don't just use 300 words, okay? Whatever it takes for you to cover all the components of this assignment, meaning obviously, where is the gene? How does it work? Why is it not working, right? What has caused the mutation, signs and symptoms of the disease. Okay. How do we diagnose and treat it? I know it doesn't say diagnosis in there, but you might want to say, yeah, you know what? We diagnose it with this blood test or whatever. And then obviously signs and symptoms, treatment is already in the assignment. So make sure that that's elaborate. Okay. The epigenetic drug, you can go to town. There's so many. I would recommend go to the National Library of Medicine, which is where I went to discuss beta thalassemia, which I'm going to show you in a minute. Okay. So with that said, what should you be doing? Well, you should be working on it now. Make sure you have APA citation. How do you do APA citation? If you don't know, there is a website, Purdue OWL, and I will send it to you with this video, as well as a cheat sheet on APA formats, and that should help you significantly. Now, what about Turnitin? The Turnitin is a platform that you turn, no pun intended, turn it in, but you turn it in, and the platform churns out similarity report to see what words have been plagiarized, what phrases have been plagiarized, and whatnot. So watch out for block referencing in text citation. Try to avoid, make sure that you don't have too long of sentences that were quoted and cited, because that will still increase the number. Be aware that it'll catch your references, but I don't care about that. That should be lighting up because that's standard, right? So I ignore that. I look at each person's report and I base it on the content, not the references. And the content should have your own words, mostly your own words. If you have to quote something, make sure you provide an in-text citation. If you do quote something, make sure it's not a block quote, because that really brings the number up. Sometimes it's unavoidable, but just be aware of that. Also know that scientific terminology is used over and over again, so that's going to light up if this, we're not doing Shakespeare, so be aware of that as well. Okay, that's everything I could think of. And then also be aware that I grade based on the rubric that's given to me, strictly by that, because that is fair, right? I give you a rubric, or the school provides a rubric with our instructional designers, and I, as the instructor, to make it fair, I show you this is what you need to do to get 20 points, okay? So it would behoove you to make sure that you review all of this content way before you upload your assignment. Make sure that every single thing in this rubric is at the max 20-point possibility, or 10-point here, right? So make sure you know how to do the APA citations. Make sure you follow the reference page as needed. Make sure that you have proper grammar, cohesiveness, and sentence structure that I can read. I don't want to see phone text info. Okay, I see a lot of people, you know, doing assignments like they were texting their friend. That's not something that you should be proud of. So make sure you don't do that. Okay, that's fine. You could text all you want, but you know, it's got to be clean, clear, concise, logical, beautiful sentence structure. Grammar is perfect. Spelling is perfect. There's no reason you always have autocorrect. Go back and check before you upload. Punctuation, commas, quotes, all that. Pay attention to detail. Lots of people do not. All right, what else? Make sure that when you talk about the drug, you mention the mechanism of action, the pharmacological action, and the efficacy in treating the selected disease, okay? So I think this is pretty clear to you. Make sure that you read this very well, the genetic diseases assignment, okay? This is worth a total 100 points. It's an easy 100 points if you follow directions and do everything to the T. Follow this rubric and read the directions very carefully and make sure all these bullet points are satisfied, okay? And then some. If you want to go above and beyond, go for it. All right, now let's give you a sample disease, because if we go to our module, let me show you. In our module 1, we had the learning activities, and I had some videos that I've uploaded that are older videos that are applicable to this course as well. And that was the foundation of anatomy and physiology, which included cell structure and function, organelles, DNA replication, protein synthesis, cellular transport. And you have standardized videos here that are way better than mine. Mine are quite campy, and you know what I'm doing now, just show my face and talk, right? But this is high tech with beautiful technology and images and videos. So make sure you study these very well. Now, when we look at the genetic diseases, there are procured, just a few in your module 1. I'm going to pick something that is not in your module 1, and it is called beta thalassemia. And why I picked this disease is because it's genetic. And also, I wanted to show you in the National Library of Medicine how you could look up any genetic disease of your choice. You could look it up in terms of books, or you can go in terms of all databases, which includes case studies and research on diseases, okay? And what's wonderful about a lot of this is that if you don't know APA format, look, it is all here for you. You can immediately cite the page APA format. So I didn't show you that, but there it is. You could do the cheat sheet way. And if you look at other diseases, let me go and pick something else. And let's say I'm going to do Ehlers-Danlos syndrome, which I'm going to do a video on that too, because this interests me personally. I have the hypermobile EDS, super flexible. See, my elbow goes way beyond. So hypermobility of joints secondary to collagen disorder, and it is genetic. So here, PubMed Central. You can go to the bookshelf or PubMed Central, and this gives you a total of, look at that, 8,200 studies on Ehlers-Danlos. So if you click on this, so I'm giving you ways to study so you know how to do your research for your disease. And if you cite this right here, click on this, here's all of the entire article on Ehlers-Danlos, okay? And if you click right here, check this out. You see where it says cite? You could do APA format. You have MLA, and well, we need APA for our school, right? Copy, and now you have your citation, and you could draw your assignment from here, okay, from the National Library of Medicine. This is my go-to. All right, so let's go back to beta thalassemia. So what's beta thalassemia? I'll tell you. So it is a genetic disease where the red blood cells do not last 120 days. Instead, they only last 30 days. So the red blood cells don't last as long. It's a terrible anemia. It's found in Eastern Europe, Turkish Greek descent, also in India and the Middle East. So that genetic structure, if you come from that background, you're at higher risk. So let's go into more detail here. This is coming from the book Stat Pearls, and these are books that we use in medical school in terms of learning our diseases. So I know this because back when I don't want to date myself, but I graduated medical school in 1995, we didn't have this wonderful internet as extensive as it is now. We had dial-up, and so they were still books at the time. Now everything's online. So let's go over the thalassemias. Microcytic means that the red blood cell is poorly developed. It's not even a good cytoplasm. It has an impaired hemoglobin structure. And so beta thalassemia is inherited, and it has a wide phenotypic severity. In other words, you can be just like sickle cell, you can have disease or trait, just the same with thalassemia. You can have beta thalassemia, where the beta structure of the hemoglobin is incorrectly structured. There's also alpha thalassemia. There is thalassemia major and thalassemia minor. Thalassemia minor, you don't have the full-blown disease, you are heterozygous. So let's go over the objectives of understanding this disease. We want to describe the pathophysiology. This is pathophysiology class. We want to be able to explain the evaluation. How do we evaluate? What are the signs and symptoms? How do we find out how someone ends up with beta thalassemia? All right, because it doesn't just show up. It creeps up as the child is growing. Sometimes it could be diagnosed in childhood, sometimes later. And then in terms of treatment, identifying the different strategies for improving patient care. So let's go over the fact that, as I said before, circling back, it is a microcytic anemia, hypochromic, meaning that the disease has an abnormal structure, global chain of hemoglobin. And in contrast with other hemoglobinopathies, such as sickle cell disease, which are completely structural, beta thalassemia refers to the mutation of the beta globulin gene, which then causes a reduced beta globin chain of the hemoglobin, and therefore its structure is not as severely damaged as the sickle cell, but nonetheless, the beta chain of the hemoglobin is affected. And as I said before, the highest prevalence is the Mediterranean Baltic nations, anywhere from Ukraine, Romania, Bulgaria, Greece, Turkey, all those countries right there, as well as Central Asia, like Uzbekistan, Kazakhstan, and some parts of the Middle East beyond Turkey, all the way into Iraq, and even as far east as India, Asian descent. All right, but not the Japanese, Chinese descent. It's mainly the Caucasian Indians of North India, as well as South India, that do carry this gene. Now, there are over 200 different thalassemia causing mutations, and these mutations are found in that beta globulin gene, and it leads to a wide genotypic variability, meaning there's a lot of gene mutations that lead ultimately to beta thalassemia. In other words, the root causes are many in terms of the genetic mutations, but all roads lead to one, beta thalassemia major. And phenotypic variability, meaning how it expresses itself physically, okay? The three classifications of beta thalassemia are always defined based on the clinical as well as lab findings. There's also beta thalassemia minor, in which you're just carrying it, just like sickle cell trait, okay? You are carrying the gene, but you don't have full expression of the disease at all, and you may be asymptomatic, maybe perhaps some symptoms of mild anemia. But if you're homozygous and you have both genes that are there, now it is beta thalassemia major. So both recessive, now you have full expression, but one recessive, and now you are heterozygous. So depending on how bad you have it, if you have thalassemia major, you're going to need transfusions pretty much on a monthly basis, and you accumulate iron. So then we have to do chelation therapy. And a lot of that is really harmful to the body. So we'll go over that in a minute. So how do you diagnose it? Through laboratory findings. And remember what I said, your assignment doesn't say, it says treatment and clinical signs and symptoms, but it doesn't really elaborate on diagnosis. So if you can mention diagnosis, such as a blood test for your genetic disease, please do. So laboratory findings of thalassemia is basically microcytic hypochromic anemia. Histologically, you're going to see the variations in size and shape, and hypochromic meaning the color is diminished, okay, when you stain it. So also, like I said, the variation of size and shape will cause the beta thalassemia major to be diagnosed via that smear. So you get a whole bunch of red blood cells, you prep it in a lab on a slide, stain it, and boom, there you go, you see it. Now, the reason for the hypochromicity is that you have iron deficiency, and you can even see it on electrophoresis. And the simplest, cheapest way is to just do the peripheral smear. But if you want to go high tech, you could do the electrophoresis or the liquid chromatography for diagnosis. And then if required, in terms of treatment, you're going to do a blood transfusion, making sure that obviously there's a blood match. The complications is, like I said before, iron overload. So therefore, chelation therapy is the way to go. Bone deforming marrow expansion because of the hyperproduction of red blood cells due to the anemia. The body thinks it needs to produce more because it's just the red blood cells are dying off too fast. All right, so etiology means cause. So what is the etiology? Etiology specifically is that the beta thalassemia is an inherited disorder from 200 mutations. We have identified 200 different various mutations that all lead to beta thalassemia, okay? Very rarely, we have some deletions of the beta globulin gene, hemoglobin B, on chromosome 11. And this is a rare occurrence, but these mutations are primary point mutations that will affect transcription, translation, and the splicing of that hemoglobin B gene. So the spectrum of the disease is huge in terms of severity. We can go from mild to very severe. We can go to normal lifespan to very diminished, dying by 35, okay? So there's basically, because we have the mother and the father gene, we have biallelic inheritance, we have 2 copies of the beta globulin gene, 1 on each chromosome 11, 1 from the mother, 1 from the father. And so we have that pool of mutations. So the genetic variability of the beta globulin synthesis is designated beta positive. Decreased production is beta 0 for absence of production of the beta, okay? So the variability is designed either as minor, intermediate, or major. So beta thalassemia minor is heterozygous with 1 unaffected beta globin gene and 1 affected. So you're beta positive and beta 0. Okay, beta 0 means that you have you decrease production, and beta 0 is for absent production. Okay. Homozygosity or compound heterozygosity is beta plus or beta 0, causing that intermediate or major. All right. So these are the more severe cases of beta plus or beta 0. Because remember, if you don't have any of the beta plus, decreased production, or beta 0, you're normal. Okay. All right. So I know that could be a little bit, you know, complicated and confusing, but there it is. As I said, the epidemiology, race and ethnicity. Okay. In this case, it's not race, but ethnicity. But, you know, it depends on who you talk to, right? Because the Caucasian race is very diverse. And so Western Europeans are completely different than Eastern Europeans. And Eastern Europeans are somewhat commingled genetically with the Middle East and Central Asia and even India. And so Eastern Europe has a plethora of Baltic countries that share their genes, and a lot of them carry this particular genetic mutation. Beta thalassemia mutations are very prevalent in the Mediterranean, in the Middle East, Southeast, and Central Asia. So Southeast is very, very diverse if you look at the map. Okay, so we have approximately 80 to 90 million carriers, and the most frequently found, probably because of immigration and lots of immigrants in America, we see plenty of people from Eastern Europe, Greek and Turkish origin. All right, so if you want to also know, the prevalence seems to parallel the malaria, because genetic mutation for sickle cell was an adaptation to becoming completely resistant to getting malaria. So that is also seen with this beta thalassemia. It seems that it has a higher frequency in this population, and the gene drift and effects is why thalassemia is more frequent in these areas. Also, where you will find the frequency of malaria heightened as well. All right, now the pathophysiology specifically is that the hemoglobin is a tetramer of two alpha globin genes, two alpha globin chains. And so what happens is, in the adult, you have two alpha chains and two beta chains. And a smaller component of the adult is hemoglobin A2, consisting of two alpha and two delta. So when the pathology happens, the pathophysiology, it's twofold. First, there's a decrease in hemoglobin synthesis, causing the anemia, and an increase in hemoglobin F and hemoglobin A2. All right. As simultaneously, there will be a decrease in beta chains for hemoglobin A formation. So that's one reason. The second reason of most significance is that the beta thalassemia major and intermedia have excess alpha chains, which are insoluble, form insoluble alpha chain inclusions, and are marked for hemolysis. In other words, they break down. So the ineffective erythropoiesis from the stem cells will lead to severe anemia, erythroid hyperplasia, too many red blood cells, stem cells with bone marrow expansion, and that is going to lead to bone deformities, facial bone deformities, frontal bossing, all those kind of deformities that can be seen in the bone. And then in severe cases, hepatosplenomegaly and severe thrombocytopenia, because now we're not producing enough platelets, and even hepatic dysfunction. So beta thalassemia minor is only going to result in a mild anemia and reduced hemoglobin A synthesis. Beta thalassemia can coexist with other hemoglobinopathies. All right. And you can have hemoglobin S, C, and E, for example, as a mutation as well. Hemoglobin S is responsible for the sickle cell. So anyway, these are all the variations of beta thalassemia, which as you can see, is quite complex. How do you diagnose it? You do a history and physical and a CBC with diff, complete white blood cell count with differential. And of course, like I said, examine the red blood cells under the microscope and even do electrophoresis. And then if diagnosis has not been determined, you're going to do other things, like, for example, genetic testing. And also, in addition, the patient will then by that point start having some symptoms. Usually symptoms start to come up, prop up anywhere between 6 months to 24 months of age. Your child will exhibit symptoms, and you will know if your child has beta thalassemia major. So if you come from Eastern Europe or India or Mediterranean or Middle East, and you marry someone, these are the things that you want to talk about and maybe do genetic testing before you have children. Severe anemia, feeding problems, irritability, failure to thrive. The child is very pale, diarrhea, irritability, fever, abdominal enlargement, hepatosplenomegaly, all of these things. And then if it gets really bad, untreated, the child is jaundice, the skin becomes brown pigmentation. There's some muscle atrophy. Some of the orthopedic anomalies where genu-valgum, knock-kneed, is one of them. And then masses of extra bone, like frontal deformities in the frontal bone, which is called frontal bossing. Maxillary bone, it has hypertrophy, long bone deformities, etc. All right. Now, so I already mentioned the CBC with diff is pretty much how you can discover it. I'm going to go on and go into treatment options. So treatment right now is still pretty much doing frequent monthly blood transfusions, and sometimes a bone marrow transplant if they qualify and they have to wait for it. Cord blood transplant is also offered as a potential cure for beta thalassemia. In patients without pre-transplant complications of clinical progression of the disease, stem cell transplantation of HLA identical siblings has a disease-free survival rate of over 90%. So this is wonderful. Cord blood transplant is also a consideration for parents who already have a child with beta thalassemia and later identify an HLA compatible fetus in a subsequent pregnancy. So if you know you have it and your child has it, there are ways to resolve it with bone marrow transplant and cord blood transplant. Also, making sure that every time the patient is transfused, you check the iron status, okay, because iron chelation therapy must get started right away, every single time, because if you have received 10 to 20 transfusions, you're going to have a higher rate of iron building up in the blood, and that can be super dangerous. All right, so that's pretty much it. You need to follow up with these patients, making sure that they stay healthy, check their liver every 6 months. Actually, liver function test should be every 2 months. Iron testing should be every 3 months. And then every 6 months, the growth and development. Also checking eyes and ears. And anybody that's 10 years of older, they need to be checked out for any cardiac issues, thyroid issues, parathyroid, endocrine, adrenal function, all of these things, especially the bone density due to the the stem cells overproducing the red blood cells to compensate for the anemias. All right, frequent MRIs to check the liver and the heart to detect any kind of iron overload. That's the reason why we check the heart. Okay, and differential diagnosis, you need to differentiate it from alpha thalassemia. That's easy test with genetics. Anemia of chronic disease, iron deficiency, sideroblastic, anemia, and then finally lead nephropathy can exhibit similar symptoms. Prognosis is poor before the year 2000, but now approximately 50% of beta thalassemia major patients died before age 35. Okay, but now since 2000, the prognosis has changed where 80% of patients live longer than 40 years in the UK. This is due to the apparition of non-invasive methods to measure organ iron before the appearance of clinical symptoms, chelation therapy, and increased blood safety measures. Why do we talk about the United Kingdom? Because we have a large population, a large Indian population, a large Eastern European population, and that is why we see much more beta thalassemia major. This is not endemic with people of Anglo-Saxon origin. All right, so complications are overstimulation of bone marrow, ineffective red blood cell formation, otherwise known as erythropoiesis, iron overload, and if that accumulates in the heart, that could result in heart failure. All right, so I hope this was a great lesson for you. I know it was a little longer than I wanted to make it. And I'm also going to share, I didn't have time, but there's the process for gene therapy in beta thalassemia. I'm going to share this particular video with you, and I hope that you enjoyed my presentation. And I'll do a next one will be on Ehlers-Danlos syndrome. I plan on doing that tomorrow so that you have 2 sample diseases, and this way you could think of something really cool for your project that's due on Sunday. All right, bye everyone.